Just a little bit of housekeeping. If you can, please make sure everyone should be muted, but if you come off mute, please make sure your phone or computer is muted if you're not a speaker. You can put all questions in the chat box for the Q&A session at the end. And if you have any additional questions, my email is right here and we'll send the slides out afterwards. My name is Tara. I'm the program coordinator for the Central New Hampshire Community Opioid Response Program. It is a Katie grant program. Also on our board are representatives from Mid-State, Sphere, Park, and Lakes Region Mental Health. Our mission is that we aim to ensure comprehensive, coordinated, and easily accessible prevention, treatment, and recovery services for those impacted by opioid use disorders in the Central New Hampshire region. Our vision is that we'll build a community to prevent, treat, and promote recovery from opioid use disorders. The program will create a local system that is free of barriers, easily accessible, and fully integrated at every point of contact to reduce opioid misuse and promote healthy lifestyles and promising futures. Just a little preview of what we have going on over the summer. We are bringing back Lunch and Learns, yay! I'm sure everybody's a little zoomed out. We have Brooklyn Rainey in July on Better Boundaries. We have Special Agent John Delina coming back in August, along with a local panel of experts in first responders and healthcare. Dr. Seefeld will actually also be on that panel, so thank you so much. And in September, we have Cindy Pierce, The Myth of Hookup Culture. And the link, you can visit Katie's website. Seating is limited. There's still social distancing requirements. The slides from today's webinar will be emailed out, and you can also view the recording on our YouTube channel, and you'll have all those links when I send this out. For our speakers today, we are bringing back Dr. Andrew Seefeld and Matt Howe. Dr. Seefeld is a board certified emergency medicine physician practicing in Plymouth, New Hampshire. Dr. Seefeld is the medical director of the emergency department, the director of emergency medical services and trauma services at Spear Memorial Hospital. He graduated from UCLA with a bachelor's of science in psychobiology and a minor in anthropology. He attended Pennsylvania State College of Medicine, where he received his doctorate. Matthew Howe has been the program director of the Plymouth House in Plymouth, New Hampshire for the past 13 years. The Plymouth House is a residential addictions treatment center in its 19th year of operation. Matt holds degrees in philosophy and psychology from Plymouth State University and a degree in nursing from Riviera University. He is a frequent guest lecturer at Plymouth State and a founding partner of Summit Health Associates, a concierge acute care and mental health practice based in Central New Hampshire. Currently, Matt is completing his training as well as a psychiatric nurse practitioner. And without further ado, I will stop sharing and let Dr. Seefeld share his screen and take it away. You're on mute.
There, can you hear me now?
We can.
Can you hear me now? So welcome to Zoom, the world of Zoom. I think we're all accustomed to the chaos, not just of COVID, but what Zoom has brought to giving talks. But Matt, I believe you are on here as well. And so honored to come back and do another talk for the group. Post-acute withdrawal syndrome. What is it? Right? A lot of people haven't actually heard of post-acute withdrawal syndrome. So when we talk about substance use disorder or we talk about addictions, you know, we have to think of the stages of withdrawal when a patient or a person stops a substance, a mind-altering substance. And there's two major stages. There's the acute withdrawal stage, and then there's the post-acute withdrawal syndrome. Okay. And the purposes of this talk is to address the post-acute withdrawal syndrome. We will do a little backstory on what acute withdrawal is, just to give some context, but the purpose is for, and I'm going to refer to post-acute withdrawal syndrome for the most part as Paws. It's a lot easier to say. So acute withdrawal, that's the first 2 weeks. And again, remember the context of someone who's been on a mind-altering substance for a period of time and then stops or decreases the dose. So the first 2 weeks will be characterized by these are physiologic symptoms. All right, physical symptoms, things like tremors, seizures, autonomic nervous system hyperactivity. So that's your autonomic nervous system, which is your automatic nervous system, right? This is the things that we don't have conscious control over, the fight or flight type response. And then intense drug cravings is characterized. And after the acute phase, we'll talk about the post-acute, but the acute withdrawal, the pathophysiology of acute withdrawal symptoms really occurs once we stop or we rapidly reduce the use of a mind-altering substance. And you'll hear things like addictive substances, mind-altering substances, any substance that can change the brain's neurochemistry can potentially create a withdrawal syndrome. So when exposed to a substance, the body uses counter-regulatory mechanisms to maintain homeostasis in the attempt to stay balanced. When the substance is removed, these residual counter-regulatory mechanisms produce unopposed effects, resulting in these withdrawal symptoms. So take alcohol, for example. Someone drinks alcohol every day for months on end. Their brain is being chronically inhibited. Okay, alcohol is a depressant. It's a central nervous system depressant. The brain is going to create an excitatory environment to counter-regulate the chronic inhibition. When we take away alcohol, then the person is now going to be in a hyperexcitable state. And this is why you see those symptoms early on in alcohol withdrawal. You see sweating, fast heart rate, seizures, things like that. So this is all about neurochemistry getting back to normal. Post-acute withdrawal syndrome, that really occurs after the acute withdrawal phase. And if about 2 weeks is where I kind of draw the line in the sand. Some are a little bit earlier, some acute withdrawal symptoms can last longer than 2 weeks. But if you want to think about it, 2 weeks up to 2 years is really the time frame that we're speaking to when we talk about post-acute withdrawal syndrome. And as opposed to physiologic symptoms, post-acute withdrawal syndrome, Paws is characterized by psychologic symptoms. All right, these are things like tiredness, variable energy, low enthusiasm, mood swings, anxiety, irritability, sleep problems, variable concentration, cognitive dysfunction. All right, so psychologic symptoms. The pathophysiology in post-acute withdrawal syndrome really has to do with the brain rebalancing itself, okay? So Paws symptoms reflect the brain's slow transition back to the normal over a period of time. The idea of tolerance is helpful to understand. Tolerance is the concept that when you take a mind-altering substance for a long period of time, to get your brain to the same level it was when you first started the substance, you have to take more of the substance. So if I take a painkiller, an opiate for my back pain, on day one, I can take one and have relief. If I continue to take that pain reliever daily or significant amounts of the pain reliever, I'm going to need more of the pain reliever to get to the same spot, to get the same physical relief that I had at the beginning, if that makes sense. So conversely, when you take the substance away from that individual, right, the brain hasn't rewired itself back to its pre-addicted or dependent state, right? And that takes time. This is the concepts of neuroplasticity, the idea that our neurons can actually regenerate, our neuron connections can actually reform, and we're not stuck in one way. We have the ability to heal, but it takes time. I like to use the example of laceration. If a patient comes to the emergency department with a laceration to their arm, and I suture the laceration, and they come back the next day and say, all right, doctor, you can take the stitches out now, right? I'm going to look at the patient and say, no, if I take the sutures out right now, I'm going to, the laceration will open back up. It takes 10 to 14 days for an arm laceration to effectively heal until I can take the sutures out. This is what the brain is doing in post-acute withdrawal syndrome. It was it has been kind of set in one way for a period of time, and now it's trying to rebalance itself back. And keep thinking of that counter-regulatory mechanism that we spoke to during the acute withdrawal phase. That was the physiologic consequences. Now we're speaking to the psychologic manifestations. And Matt, not to overtalk, but if you have anything on these, feel free to hop in. It's hard to do Zoom as two colleagues who love this science, but Paws is the direct evidence that the brain is healing.
And the presentation is relatively basic level, so I apologize if it's too elementary for some attendees, but to sort of recap what Andrew said, analogically, we've got neurotransmitters in the brain, which are excitatory or inhibitory depending on what part of the brain they're going to. So you can think of them as a gas pedal or a brake pedal in many cases. And we're taking a certain drug, we may be stepping on the gas pedal or inhibiting the brake pedal. And when we take that away, in the case of benzos or alcohol, as we used for an example, we've got a whole lot of artificial brake pedal. And because our brain wants to get back to a state of homeostasis, it's not putting any pressure of its own on the brake pedal. And then we take the benzos away, we take the Klonopin, Valium, Xanax away, we take the alcohol away. It's all gas pedal and no brakes. And this is the acute phase when we are incredibly uncomfortable and at risk for seizure, because just like your car, if the brakes don't work and the gas pedal's all the way to the floor, you're going to be going very, very fast. It's going to be very, very scary, and you're in great danger of a crash.
Excellent. Thanks, Matt. So let's talk about symptoms. There are many symptoms associated with Paws. Though each symptom is fairly common among people, the exact number, combination, and timing of specific symptoms are different for each person. Physical differences between the people, as well as differences in the types of the substances that were used or abused and the amount and frequency of use, affect each individual's experience of Paws. So it is variable. But what stays pretty consistent is that all symptoms during post-acute withdrawal syndrome, they impair various aspects of an individual's emotional state. Okay, that's key. They are intermittent, coming and going over days and weeks, and they do not impact a person to the same extent over the entire course of their withdrawal. This isn't, 2 years of psychiatric, discomfort. It's intermittent. They do impair, and they certainly don't impact you, and they do get better. And as we develop skills around the emotional dysfunction that predated the substance use problems, you can really create an environment for the person or the patient that they can really understand where these emotional breakdowns are occurring, why they're occurring, and they can walk through this. So that's important. So some specific symptoms, and you're going to notice the theme here. All these symptoms really have to do with the brain trying to rebalance itself. So neurochemistry, neurotransmitters that have been artificially, as Matt was saying, artificially pumped up for a period of time, now trying to rebalance themselves. So mood swings. The brain of a chronic substance user or abuser has become adapted to a constant supply of mood-altering chemicals. That's what we just spoke to. When the substance is removed, periods of mania or depression can occur for no apparent reason while the brain is rebalancing itself. Anhedonia. Anhedonia, this is what anhedonia is like. Anhedonia is the loss in pleasure in doing anything. It's severe. So all addictive substances boost neurotransmitters and augment neural pathways that make the user feel good. That's why substances are abused. They make you feel good. Once these substances are stopped, it can take some time for the brain to produce normal levels of these, quote, feel-good chemicals on its own again, the dopamines, the norepinephrine, serotonin, so on and so forth. Until the brain does, an individual may find that nothing seems fun or interesting anymore, even activities they used to enjoy. And at the end of this talk, we will give some, encouragement as well as some insight into things that can facilitate getting through these down periods. Anxiety.
And if you don't mind, it really quickly, when we say good, a more accurate term, maybe better, where better is a comparative, and it can't exist in a vacuum, because I'm sure many people in attendance are in the field or work with patients or clients or people who have loved ones who suffer with addiction and alcoholism. In the later stages, it certainly doesn't look good, but it's better. And again, better is a relative term. So by the end, I'm so uncomfortable and the conditions of my life are flooding in that I drink or use because it produces something relatively better. In the case of alcoholism, I've had many clients who they drink and they get either very, very angry, or they get very sad and teary. And what they'll report is it's not good, but it's better than the emptiness I feel when I'm not drinking or using. So that term good can be confusing sometimes, because viewing it from the outside, it certainly doesn't look good. But I think it makes light of just how miserable things can be in early sobriety, that it would be preferable to go back to something that would actually elevate you to the state we see while someone's actively drinking or using.
Perfect. Thanks, Matt. So anxiety, stopping an addictive substance is a major life change that is often accompanied by a great deal of anxiety and even panic attacks. Now, if you add, as Matt was speaking to, the alcohol or the benzodiazepines, these are coping mechanisms that people use to treat an underlying anxiety or panic disorder, right? So now when you add that to the mix, you're creating an almost a double whammy here, where the patient is not only suffering from an anxiety or panic disorder in a natural way, but then taking away these medicines or these drugs that they were using as a coping tools now kind of created a perfect storm for even increased anxiety. So insomnia. Many addictive substances affect sleep patterns, and the brain adapts to long-term use. Once these substances are stopped, it takes time to reestablish healthy sleep patterns. And again, you can see there's a common motif here, right? It takes time. This is healing. The brain is healing. And I continually reiterate the fact that this is, when we are feeling these feelings, this can be looked at as negative or positive. And I try to encourage people to consider that the depression that they're feeling today is likely a result of the withdrawal syndrome. It is not going to last forever, and that it is a sign of healing. And that putting a positive spin on it will help people cope with the days or hours or a few days worth of the mood imbalance. Cognitive impairment. Another symptom of neurotransmitter imbalance. Difficulties in thinking clearly and maintaining concentration are temporary, and they don't signify permanent brain damage. Symptoms include forgetfulness, language disturbances, impaired judgment, attention difficulties, difficulty with reasoning, planning, problem solving. And I'll take this, do a little aside here. As a practitioner of medicine, I, especially in the emergency department, I will have patients come to me with lots of these individual symptoms. And it's important to be mindful that in the context, the bigger context of a prolonged withdrawal syndrome, a post-acute withdrawal syndrome, that these patients often don't need to be treated for these symptoms, right? Attention difficulties don't need attention deficit treatment, in my clinical opinion. These are signs of the brain healing. So it is important, especially in my practice, to dive a little bit deeper on patients' symptoms when they present to the emergency department, or if I was in a primary care setting, so that I'm not misdiagnosing someone with a more chronic underlying illness and putting them on medicines that is really only going to impede the healing of the brain. That's not to say there isn't a role for antidepressants and anti-anxiety medicine in the patient population that we're speaking to. But we do want to be mindful of this syndrome, especially when we're talking about treatment. Depression and fatigue, and this will kind of spin off of what I was just speaking to. You know, many people who stop chronic drug habits experience such intense depression and fatigue that they actually fit the criteria for major depressive disorder or chronic fatigue syndrome. You know, unlike these conditions, however, these symptoms are a phase of readjustment in the brain and generally diminish without treatment over time. And Matt, I don't know if you want to speak to this, but I suspect that you have many, many clients that come to the Plymouth House in the context of a post-acute withdrawal syndrome, and their first thought is, I need to get on a medicine for this and for that. Do you have any thoughts on that? Or
yeah, one of the factors that complicates primary treatment, all of our clients here come to us post-detox. The line between acute detox and pause, of course, is blurry. There's not some set of criteria where, okay, yes, now you've entered into this phase. So, of course, a lot of the folks that we get here are in the late phases of an acute detox. They're uncomfortable, but then they're here for 2 weeks, 3 weeks, 4 weeks. They've got these symptoms. They're anxious, they're sleep deprived, they're depressed. It makes it challenging because it's difficult to get the hard work of primary treatment done, even under the best circumstances. But when you've got clients who are now suffering with these other symptoms, it makes a difficult process even more difficult. Also, there's the temptation of clients to want to use more drugs to treat those symptoms, and the instinct of many providers and healthcare professionals and clinicians, of course, is, well, this is my patient, this is my client, I'd like to make them comfortable. So why don't we prescribe X, Y, and Z to help with these symptoms? Unfortunately, what happens frequently is we get into the mess of polypharmacy, and we end up chasing our tail with these symptoms that, as Andrew said, we can think of as the brain healing, and as in some cases, you know, it's appropriate. You're not going to sleep well when you're coming off of a heroin binge, a fentanyl binge. It's not going to happen. And this absolutely, of course, doesn't mean that we're going to be punitive or we're going to deny someone something relatively benign that's going to help them with sleep. But what I've seen a lot of over the last 13, 14 years, and I've been seeing less of it lately, and hopefully that continues, is prescribing of another potentially harmful substance, such as a benzodiazepine. So we've got someone who's in the post-acute stage of opiate withdrawal, and they're struggling, which you're going to struggle. And then we introduce something like Klonopin, which has the potential to be terribly, terribly addicting. And now we've just sort of made the waters a little bit more messy. And it also, for clinicians, it makes it a lot harder in some cases to work with a client and say, yeah, part of this is pause, and part of this is the lack of coping skills that precipitated why you used and why you drank, as another route of coping that works well in the short term, but is disastrous in the long term. So it can get even more muddy here. And sometimes our best efforts to help our clients and treat them, it takes us backwards. It takes the patient backwards a step.
Perfect. Thanks, Matt. Using dreams. You know, the subconscious desire to resume some aspect of drug-using lifestyle may manifest itself in vivid, realistic dreams. You know, these can be very disturbing for a person in recovery. These dreams are not a warning of impending relapse. They simply reflect how deeply ingrained the substance-taking compulsion was in the brain, right? So it takes years. Drug cravings. You know, people with post-acute withdrawal syndrome often have intermittent cravings for the substance or the medication that they took. You know, because most of the intense physical symptoms have subsided, that was the acute phase, the individual may feel physically healthy but continue to experience negative psychological symptoms, which make the return to drug use seem appealing. And I'll just say that, you know, and that's why, you know, a treatment, right? A treatment has to be multimodal. You know, taking a person with a substance use disorder, if that's who we're speaking about, and taking the substance out of that person and calling it quits at that point is not going to work long term. You've got to do the emotional work, right? You have to do the psychological work that predated the substance use issue in the first place. So the drug cravings, you know, make it difficult if we don't have that foundation moving forward. Sensitivity to stress. You know, many people dealing with the effect of Paws find that their threshold for daily stress is very low. Trivial irritations feel like the end of the world. The substances used or abused have been a primary coping tool for life stresses, and the removal of them can be troubling to individuals. New life skills must be learned and tools developed to handle complex emotional disruptions without relying on the substance. That was what I was speaking to. So just going to go a little bit on drug classes. Might give you a little bit of insight. We will speak to, there are many different drugs that can result in post-acute withdrawal syndrome. This will speak to the big classes, including alcohol, benzodiazepines, antidepressants, opiates, and your psychostimulants. So alcohol, how does alcohol work? Alcohol is a sedative drug which activates inhibitory receptors. Those are your GABA receptors in the brain. The brain then adapts, as we learned at the beginning of this talk, right? Chronic inhibition. So if it's chronically inhibited, the brain is going to chronically excite itself, right, in the absence to counter-regulate, to find that homeostasis, and the person is still drinking every day and so on and so forth. However, when that individual who has become dependent on alcohol stops, now you've created that hyperexcitable nervous system, and that's where the symptoms come in, right? The tremors, the seizures, the sweating, the fast heart rates. Less severe symptoms such as the sleep disturbances, mood swings, and anxiety can be seen, you know, several months to up to a year or two in post-acute withdrawal for the alcoholic brain. Benzodiazepines, you can put them from a physiologic standpoint very similar to alcohol because they work very similarly. Benzos, they are GABA receptor activators, so they're inhibitory, and chronic use also causes the brain to then switch to a hyperexcitable state. You can imagine that when we stop benzodiazepines abruptly, or we decrease a large dose to a lesser dose, you know, you're going to have excitatory symptoms. Pause can be quite difficult for patients who have taken benzodiazepines for an underlying anxiety or panic disorder, because the withdrawal syndrome in itself is anxiety provoking. So again, as I spoke to earlier, you get hit twice as hard. Symptoms of post-acute withdrawal from the benzodiazepines can mimic disorders such as depression, panic disorder, OCD. And again, I'll bring up the point that in someone who is coming off of benzodiazepines or even alcohol, it's important for providers to understand that there's going to be psychological manifestations of the withdrawal period. It is not a permanent withdrawal. It is not permanence. It is simply reflective of healing of the brain. And I would be cautionary to start someone on antidepressants, perhaps, that are coming off of benzos. Obviously, case-by-case variation exists. Antidepressants. So these are your serotonin reuptake inhibitors, your serotonin norepinephrine reuptake inhibitors. And they work by increasing the amount of serotonin and or serotonin and norepinephrine by blocking the reabsorption of the nerves, by the nerve cells. The exact mechanism of how these drugs work to improve depression is debated, but certainly involves adaptive changes in the brain, right? Because it takes several weeks, up to 6 weeks, to actually notice any clinical effects from these medications. So there's change that has to occur in the brain's neurochemistry before we affect any difference for the patient. So because of that fact, it's not surprising that long-term effects are commonly reported when patients stop taking these medications. Something to think about. Opiates. All opiate drugs, they work by activating the opiate receptors in the brain and the spinal cord, which modulate perceived pain, induce a feeling of well-being, and produce at large doses a euphoric high. The body adapts to the chronic overstimulation of opiate receptors by actually increasing the number of receptors on the brain and spinal cord cells. This is that idea of tolerance, right? You need to have more of the opiate to get to the same effect because it's inadvertently increasing more receptors. The downside here, one of the downsides, is that our body's natural endorphins, right? These are our natural, if you want to consider them like the natural happy molecules, right? The natural pain relievers that the human body has are actually downregulated because of this influx of synthetic opiate that's this exogenous opiate that's coming into the body. And you can imagine then that when you take away the opiate, this exogenous opiate supply, you've now got a body that has a dearth of its own natural endorphins. And you can imagine the psychological as well as the physical minefield that these patients are living into. It's been proven that the pain threshold for a chronic opiate addict is markedly and statistically less than someone who has not had problems, dependence on opiates. And then you add the psychological manifestations that lack of endorphins can result in. And the psychostimulants, so these are your cocaine, your amphetamine based. And again, this isn't just illicit drugs, Ritalin, Adderall, these are all amphetamine-like medications that we prescribe for certain conditions. Understand that there is a cost when someone tries to get off of these medicines. So stimulant drugs, they work by increasing dopamine and norepinephrine neurotransmitter levels. And they do provide some of the clearest evidence that post-acute withdrawal syndrome is a true medical condition and not simply an extension of an acute withdrawal syndrome. The psychological symptoms of Paws, such as paranoia, anxiety, impulse control problems, depression, and other emotional regulation issues are frequently observed in chronic users who stop stimulants suddenly. And there are other drugs, marijuana, antipsychotic medications, anabolic steroids, all have Paws-like symptoms that are associated with withdrawal syndromes. So what are some risk factors for post-acute withdrawal? Factors that influence the type and intensity of the symptoms include the pattern of substance use or abuse, duration of the addiction or dependency, intensity of the drug use, genetics, a person's physiology, their physical makeup, a person's psychological makeup, and then the existence of other physical or psychological conditions. So steps can be taken to manage post-acute withdrawal syndrome and improve your well-being in recovery, okay? Stay educated, become aware, become educated about both acute and post-acute withdrawal syndromes so that you know what to expect as you navigate the recovery process. Stay positive. Acknowledge how recovery is changing your life for the better. Stay healthy. A healthy diet and exercise help your body and brain heal quicker, bolstering immune system activity and restoring healthy balance to the neurotransmitter levels, and can reduce the anxiety, stress, and improve sleep, right? The natural endorphins get to start playing the game again, right? But it does take time. Stay mindful. Find supportive environments where you can expand your self-awareness. Consider journaling, meditation, other self-reflective processes. And then stay connected, right? If we're speaking about addiction, the opposite of addiction is connection, in my opinion. right? Stay connected. Surround yourself with a community of individuals that can support you along the way. That is paramount to a success in recovery. And we'll just, I'll just finish with just kind of a slide on the summary, just some key takeaways. You know, symptoms of post-acute withdrawal syndrome manifest themselves after the end of the acute withdrawal phase. And as Matt said, it is blurry, right? But the reality is once you've gone through the physiologic withdrawal symptoms, you know, then the psychologic takeover. Different addictive substances have different long-term effects on the brain, and the symptoms of Paws will be different depending on which substance or combination of substances were misused, abused, or used. Effects of this syndrome may continue from anywhere to 2 to 3 months up to several years. Remember that symptoms of Paws come and go, lasting days or weeks, and are separated by periods that are symptom-free. Though the experience of Paws can be unpleasant and frustrating, remember that these symptoms will subside with time, and they do represent healing of the brain. I cannot emphasize that enough. Patience and understanding are the keys to successfully navigating post-acute withdrawal syndrome and learning how to live a healthy and happy life in recovery. Lots of references here if anyone wants to see them. And then I just have, I'll put a little plug in for my LifeLink. You know, my LifeLink, my twin brother is in recovery, and he developed a virtual recovery platform that I've been helping him with for the last 3+ years to integrate. It's a free app, and it offers anyone who suffers from substance or behavioral addiction access, and just even emotional addiction. There's people on the app that don't even have problems with drugs or alcohol or even behavioral addictions. Emotional addictions primarily, you know, just as a means to connect with one another and support each other. I do talks on science of addiction and so forth. Again, it's a free app, but I figured I'd throw it out there if anybody's a practitioner and they have patients that, especially in the context of COVID, where, you know, people aren't getting in-person, you know, meetings as much, or they're afraid to go out. There's so much isolation and like I said, the opposite of addiction is connection, right? And if we take away the ability for other human beings to connect, we're going to have we're going to create a better environment. It's not better, but an environment that's going to foster addiction and substance and behavioral maladaptive choices. So anyways, that is it for us. Matt, do you have anything to add to that?
No, that was it. We can answer some questions if there are some questions.
We do have a couple in the chat box. If someone is to take Adderall as prescribed, does that still increase the individual's likeliness to become addicted or dependent?
Likeliness to become addicted or dependent. So yeah, that's a super difficult question, right? You know, what defines the person that takes a substance daily and isn't abusing it? They're dependent on it, right? They're dependent in many ways to function, you know, but are they addicted to it? That's difficult. You know, I don't think science has actually figured out that answer yet.
One of the signs, oh, sorry, go ahead, Andrew.
Yeah, signs and symptoms. Go ahead, Matt.
I mean, we could see in someone, if someone is taking their, let's say, Adderall as prescribed, they'll certainly be dependent to some degree, depending on, you know, dosage, frequency, etc. I think with someone who's taking Adderall, what the manifestation that you would see of someone who's becoming addicted would be they're taking more than they're prescribed. They're running out of their medication early. You know, they're calling their prescriber and saying, oh, geez, I lost it. Because what we usually see is this sort of phenomenon that manifests. And it's not just tolerance. It's this craving for more and more and more and more effect. So there are certainly people who manage their Adderall prescription, for example, and they don't abuse it and they take it as prescribed. And I don't know that necessarily predisposes them to abusing other substances, but with the clients that we've seen and the patients we've seen, we've had lots of folks who come to treatment for alcohol, come to treatment for opiates, benzos, etc., and then they'll make an attempt at using something like an amphetamine, like Adderall. Since they're wired that way, I've seen very little success in someone maintaining taking a drug like Adderall successfully as prescribed. Same with benzos. We've got, lots of clients and patients who they go to treatment for alcoholism and they've still got that anxiety that, most likely predated their alcoholism. It's probably what's at least one of the factors in why they started drinking was to try and manage the anxiety, and they'll get prescribed a benzodiazepine and they can't manage it. Same thing with, pain management. There are people who, I have disc injuries and I've got neuralgia and paresthesia, but there are certain drugs that are just off the table for me because of the way that I'm wired. So,
can I just add a little bit more? That was my question. It's on behalf of my 15-year-old brother who is taking this, and addiction runs in my family. So that was like my thought of just, he is taking it as prescribed, but is there any, more like additive effects of, because addiction runs in our family, if it's going to affect him that way? But thank you very much for answering that.
Thank you. How is Paws covered by insurance? What treatment and support is required?
So, when we look at where Paws is going to primarily manifest, your most insurances will pay for primary treatment. So you're looking around a month. And then hopefully the next step down level of care, be that PHP or IOP, which is going to extend it out, another month. So you've got pretty good support, hopefully, for a couple of months there. After that, we're looking at ideally a good therapist and lots of peer support. The ideal trajectory for someone post-detox is to go to primary treatment, follow that up with an IOP, and then be in aftercare, a sober house or extended care, to provide social support and an atmosphere that's conducive to seeking out whatever kind of peer support is right for that person. Because as Andrew said, this is extending out a long time and it's really tough to get insurance to pay for that. They don't want to pay for anything. So that's why it's really important to try and stay around recovery, around treatment for as long as possible. And ideally you get to a point where it's sort of you're good enough at recovery that you have your support system. You have a peer group in recovery and it's part of your routine. So working with someone every week is just part of your routine. Self-care becomes a routine.
Thank you. I'm thinking of how awful it must be for people who become incarcerated, who go through acute withdrawals and Paws in jail. Is there any research on the trauma of that specific experience on the brain?
So I don't know if any literature exists on that, but I can tell you, having worked with a large population of folks who were in jail or prison, they go to pieces, many of them after they come out. They're able to manage while they're in prison, while they're in jail, even though it's in many cases very easily accessible drugs. But because of the structure they have, they're able to sort of grind through the pause. The problem comes when they don't develop sufficient coping mechanisms. They leave that environment and they're in a place where life is just overwhelming. And this happens to everybody, pretty much everybody. we drink and use because it's medicinal and it works. It works really well. Opiates, for example, are an incredibly effective antidepressant. If you're depressed and suicidal, you know, heroin will do a terrific job of making you feel better. The problem is it's a very short-term solution. It's disastrous in the long term. You try to stretch it out, you're using alcohol to cope with anxiety, loneliness, dissociation. You're using opiates to cope with you know, a lack of connection or frustration with your marriage or something. The problem is twofold. One, the efficacy decreases over time, and two, any coping mechanisms that would have been sustainable in the long term, healthy, you fail to cultivate. So when you do go to treatment or detox and someone takes those things away from you, if you don't develop sustainable coping mechanisms, you're left with nothing. You're sort of like you're like an infant in the woods. And we've seen that a lot with folks who are coming out of being incarcerated as they get back to the world, and they haven't had a chance or the opportunity while incarcerated to develop coping skills. They make it through the pause. They just, once they get out, they're back. They're in the real problem, which is I don't have the right tools to navigate life.
Right.
That's important too. You know, I would reiterate that, you know, the post-acute withdrawal syndrome is complex, but it's the brain's neurochemistry, you know, finding itself to the pre-addicted state, right? But if we were talking about substance use disorder, you know, patients with substance use disorder, they have emotional problems that predated right? They have childhood trauma, right? We're learning about trauma. That's a huge thing for a predictor for substance use disorder. So, you know, they have all these emotional dysfunctions that predated the substance use problem. And so if we don't create an environment that Matt's speaking to that's conducive to addressing the emotional breakdowns, then the patient can finish, you know, and 2 years into it, and no longer be having physiologic or psychologic manifestations of pause, but certainly have psychologic breakdowns as a result of not learning or not getting in tune with what really was going on, right? Alcohol and drugs were never the primary problem for a substance abuser, right? They were a great solution to an underlying emotional dysfunction that predated all of that. So address the emotional breakdowns, and guess what? The substance use and behavioral addictions are a non-thing at this point. So.
I'm probably going to butcher this, but is zopiclone as prescribed for sleep addictive? So, zopiclone?
Ambien?
I think, is it Zolpidem? Is it Ambien?
Ambien.
So, the what they call the Z drugs, they are physiologically, they're very, very addictive. They work really well in the short term. If you've ever flown, you guys who travel, before we all stopped traveling, but I flew very, very frequently. I was traveling quite a bit, and you know, you'll see the people next to you who take an Ambien before the flight, and then they sit next to you and have a glass of wine, and they're gone. It's like sci-fi, like going through a time warp. And if you're someone like me that doesn't really like to fly, you know, you have this anxious flight and the bumps really bother you, and it seems like the flight took 4 days, and the person next to you closes their eyes, and then you have to actually wake them up saying like, oh, we've landed, we're at the gate, everyone's off the plane. And you kind of hate them because I'm jealous of them. Most prescribers are pretty cautious about prescribing long-term drugs like Ambien because it's really, really difficult to stop taking Ambien. So the responsible thing to do is, if you are going to prescribe something like that, is to let the patient know, here's the possibility, here are the difficulties that could very likely arise if you're on this long term. If you do decide you're going to stop taking it, it's going to be pretty painful. And most of the people that I know that have had been taking drugs like Ambien nightly for a long time, it's pretty awful when they try to discontinue. And again, it's got to be balanced. I understand sleep deprivation and not being able to sleep is also awful. But yeah, they're pretty tough drugs to come off of. And it's pretty hard to sleep without them. It takes sort of a while to get there. The same education should be provided to patients when they're being prescribed, say, an antidepressants. Some antidepressants have a discontinuation syndrome, and that, antidepressants on the whole are certainly more benign than Z drugs, but everything sort of has a price. And antidepressants absolutely save lives. I mean, antidepressants definitely save lives, but there are some, especially the SNRIs, where if for some reason you decide you want to discontinue or change meds, it's going to be pretty uncomfortable in some cases.
Definitely. Do you have any recommendations for how recovery community organizations, recovery coaches, or CRSWs can integrate awareness about Paws into their work with participants?
I mean, that's part of the reason why I wanted to do this talk. I mean, I guess this is kind of this is me giving my 2 cents and trying to get this out to the community. Education, willingness, openness, honesty, and being transparent with patients. As a physician, my practice in the ED, in the ER is, I really stand by transparency. I'm going to give you a medication that can do this, and this is the side effects. Patients have the right to know. And I think as providers, sometimes we think they just won't care. Well, that's not really for me to decide, right? Give the patient the information and let them decide. So.
Definitely. There's a comment on here that the cognitive impairment makes sense as to why people may miss their appointments.
Yeah, and that's another factor that makes it muddier as well, especially with, you've got an alcoholic who's been drinking very heavily. We see it all the time where you're starting to get some organic damage, and it's just another factor that makes the whole thing muddy.
Definitely. SSRIs are often prescribed for anxiety to avoid prescribing benzos. Can you speak to the addictive qualities SSRIs in that circumstance, particularly if alcohol has been a form of self-medication?
So SSRIs, they're not going to do anything. I don't think they have an addictive quality because they don't really have any sort of PRN value, meaning benzodiazepines, I start to experience anxiety or discomfort. I take an Ativan, I take a Xanax. It's going to work pretty quickly. I'm going to get relief pretty quickly. And I've essentially, to oversimplify it, I've trained myself to take a Xanax or an Ativan when I experience discomfort. And that's just going to turn into a feedback loop. Whereas if I have discomfort and I go and say, let me go pop an extra Prozac, it's not going to establish that sort of conditioning response, because these are the drugs that take a little while to get up within their therapeutic window, and people don't tend to get the sort of euphoria or visceral relief they get from a drug like a benzo. So they're not addictive, but there is a discontinuation syndrome with some of them, especially the SNRIs. Lots of us know, drugs like Effexor, we want to change for some reason. We don't like the side effects. People underestimate the suffering that can happen as a result of that. People don't get it. I've had lots of clients say, hey, I'm trying to come off of this SNRI and my brain's zapping and oh, well, it's just an antidepressant and it's not a big deal. And no, people really suffer. And again, that's not to say to not prescribe them. It's just like Drew said, it's be transparent with patients and say, hey, here are the pros, here are the cons. You're depressed and suicidal. Like, we got to do something, and understand that this may help, but there's still going to be a price. It's just, if you're prescribing a statin, the statin can help you, but here's the price of the statin. Here's the price of a proton pump inhibitor. Here's the potential price of an ACE inhibitor. All of these drugs. I have cardiac issues, and I had a cardiac arrest a few years ago at Spear, and I had a stent placed, and my cardiologist, who's amazing, down at CMC, I have another coronary artery that's still, clogged up, and it's not at the threshold yet, but to me, subjectively, it feels like a ticking time bomb in my chest. And I said, can we just go please place another stent? And she said, you need to understand that a stent is not a miracle. A stent is its own medical problem. Yeah. You are fixing one problem, but you're creating another medical problem, because now that artery is not as flexible. The flow through that artery is going to be different. So you have to pay for everything. There's some price to be paid.
I have one more question here. We got to close right up at 1 because we have another webinar coming on. I'm a working mom who has been diagnosed with severe depression. She is strongly opposed, working with a mom. She is strongly opposed to using any drugs to help with her depression. What are the odds of psychological therapy being enough to help her without using any depressants?
So finding the type of therapy that someone is willing to engage in, finding a talented therapist, these are massive. There's lots and lots of people who are depressed due to, and it's an oversimplification, but some extrinsic situation. So let's say I'm in a relationship that's terrible. My spouse is, psychologically abusive. I hate my job. I've suffered some loss of some person I love. There's appropriate depression around those. And if it extends past a reasonable amount of time, reasonable depending on the individual, therapy can be, and oftentimes is, exactly what that person needs. Can you help me see what these problems are? And let's work on some exercises, develop skills and ways to make changes in my life. But there is a point at which someone's in such a deep hole that that's not going to work. And when we have someone who wakes up in the morning wishing they were dead and they can't make their appointment because they can't move, they're in that place of abolition where they would kill themselves if they could just get out of bed. That's at a point where I think a pharmacological treatment is probably appropriate. And
great.
SSRIs, all things considered, are fairly benign drugs. It doesn't mean they don't come with side effects and a cost like everything else. But if I had someone that I loved or was cared about and they had anxiety, I'd much rather see them on sertraline than have a prescription for PRN Xanax.
Yeah, great. Thank you guys so much. There's tons of comments in the chat here about how much everybody enjoyed this.
Thank you.
So we'll definitely be bringing you guys back for new topics in the future. Thank you, everybody, for attending.
Thanks, guys. Thank you all for having us.